I'm Dr. Faisal Ghairi. I'm going to present two challenging cases. The first one is about the hypermobile kidney. She's a female, a 51-year-old, presented with 7 days history of bilateral loin pain, more on the right side. The pain score was 7 out of 10. This is the CT KUV we did. You can see that she has left upper calyx stone and left ureteric stone.
You can say something actually, so you won't be able to see. Good.
So she's a 31-year-old female presented with 7 days history of bilateral loin pain, more on the right side, and the pain score is 7 out of 10. This is the CT scan, which showed that she has a left upper calyx stone and a left ureteric stone and a right UVJ stone. And she has also a right renal stone. So this is the measurements of the stones. The one on the right kidney is 9 by 5 by 5 millimeter, and the other one on the upper ureter is 16 by 9 by 6 millimeter. And the ones on the left side, there is a left upper calyx stone 16 by 9 by 15 millimeter, with the left upper ureteric stone 12 by 6 by 6 millimeter. This is the first image when we inserted the bilateral DJ stent as an emergency. It was on July 2021. After that, she was admitted electively for left URS and the right ureteric stone pushed back, and the right PCNL was done at that time. And it was planned for left PCNL. In probe, when we started on the right side, we fixed the ureteric and we did our puncture. When we inserted the guide wires, we found that the kidney moved toward the vertebral column. And when we inserted the sheath, we found that it moved toward the other kidney. And this is the...
So when we did the retrograde study, it's confirmed that the patient has two moiety or Dobrik system. Yeah, so we inserted two guide wires, one in the upper moiety and the other one in the lower moiety. And as you can see, as soon as we introduce both guide wires, we start noticing that the kidney has been pushing more medially. So upon inserting the access sheath, kidney moved almost to the other kidney. Dr. Mohammad, if you have this case in your OT, and while you are inserting the access sheath, how do we approach the patient?
First of all, I'm going to ask you, is this case done supine?
No, it was prone position.
Okay, so is she a thin lady?
She is a thin lady, with body mass index of 28.
Yeah, with very thin women, you may have a very mobile kidney. So what I would do extra is to put something to support the kidney below her tummy, and once I go in, I would try to go with that support in so I don't push it. But when I push the guide wire, when I do my initial puncture with the needle and I have the wire down, you're doing sequential dilatation or balloon?
No, balloon dilatation.
Balloon dilatation. Yes. Have you used the 8-10 coaxial set?
Yeah, first of all, we use like the tip from the dilators. We start with 8 and 10, then the balloon.
So, did you do a support under the...
Yeah, there was a support underneath her abdomen. However, as I told you, as soon as we introduce the both guide wires, we start moving, seeing the kidney moving with us only pushing the guide wires.
Again, what I would do, I would try to put more support in. If the kidney continues to go in, I will go and I put a nephrostomy tube. this has happened to me if I fail from both axes, but you don't keep on trying and put a nephrostomy tube, then later on that tract will probably fibrose, and then you can do a second stage procedure. But the safest thing, not to keep poking all areas, as most of the pseudoaneurysm and bleeding come from the needle itself. It's not from the dilatation. And we know this from animal studies or from percutaneous surgery. I'm sure you managed to do something. That's why you showed
well,
the
actually, when we went for the nephroscope, which was 26 French long nephroscope, we tried to figure where's the stone. The stone actually was, as you saw from the CT scan, it was in the UBJ. However, once we pushed the stone backward, it moved to the upper calyx. So that's why we have two guide wires. One was in the upper moiety, one in the lower moiety. And our puncture was in the lower moiety one, so it was in the middle calyx. Every time the nephroscope was moving inside the kidney was going further and further medially. Like whenever you were trying to navigate for the stone, the kidney was moving forward and forward. So
I think you're trying to push me to say, put a nephrostomy tube, inflate the balloon, and pull the kidney and dilate the upper core. But what I would do, I would stay, put a nephrostomy, and come later. Actually, I don't know about my colleague.
Not a good idea. But actually, what we did, show us the next step. We introduced our nephrostomy. Later on, we just did an integrated stenting, and the patient was later on going for retrograde flexible arthroscopy, and we managed to extract the stone. But the idea of putting you said Foley catheter, inflating the balloon, and pushing the kidney to your side. Huh?
That's actually what I mentioned. You have a great access, so why do you lose it for a stone that's large? I would have put in a nephrostomy, come for a second look, and you probably can do something with that big sheath in. So you lost that access, which was...
First of all, I'd like to thank you that you inserted two wires from the start. So you have to plan your access from the start, and especially in the cases of cellular pelvis. As regard the hypermobile kidney, first of all, it is most common in young aged female, as you said, and also in old age thin patient. So you suspect the hypermobile kidney. The first problem, when you puncture it, mostly the kidney moved in front of you, and it is not easy to puncture the top of the calyx, but you will try and you will succeed. Here we said you should have the extra long ambulance, the 21 centimeter ambulance. If you have this extra long ambulance and the extra long nephroscope, you will not face any problem in this case.
So your solution is we should use long axis.
You should have the long axis, and you should have the long nephroscope, the extra long nephroscope.
No, I don't have actually the long axis.
And
we have long nephroscope, but we don't have the extra long axis sheet.
You should have it. But the second point, once the ambulance inside the kidney, during the dilatation, and the kidney will come back again.
Actually, it was not coming. It was going more and more medially. Actually.
Once the ambulance is inserted, everything it will be retained. But if it is not occurred, you should have the extra long arm. You should have all your armamentarium from this. Thank you.
Hassan.
Can I just ask what guide wires were you using there? Were those implants extra stiff?
Sensor guide wires.
Sensor, yeah. So the one thing that I've observed as well is that it's usually young females, they're thin, and the kidney moves a lot. So I see this quite often. But I prefer guide wire to dilate over and also to try and fixate the kidney a little bit. Implants extra stiff guide wire. So not a sensor, not a Benson guide wire, but the implant's extra stiff. It's a bit more rigid. And why that's helpful is when you dilate, it allows you to actually fix the kidney to some degree, so there's less motion. And I think the point that was raised as well, sometimes when you get the sheath in over that guide wire, by just sliding the sheath backward, you bring the kidney back toward the flank. So an extra stiff guide wire here, I think, could help.
Would a single shot dilatation here be more favorable than sequential dilatation? What do you think?
So every time you have to put your implants in, bring it out, bring it on, I think you're pushing, right? I think that the beauty of the balloon is it's one one step, and any movement that you induce by pushing the balloon just happens once. If I think exactly correct. And I think the other key point too of these really mobile kidneys is when you're putting the access sheath in, it's not a push. It's a spinning motion. You're trying to use that bevel to kind of cut through the subcutaneous tissues, the perinephral tissues, and that way you're not really pushing the kidney away. The kidney's sort of staying in position and you're sliding. So we always teach our residents that it's not a push, it's more of a rotational spinning motion, and that's what it really helps in a situation like this with that kidney.
Dr. Wissam, would you do, I know you're doing supine PCNLs. Would you
Yeah,
do this in supine
in
PCNL?
supine cases, we find this cases more often actually. The kidney is more mobile than supine cases, and especially in female ladies who had babies before, we do face this problem. I agree with all the tricks, and another thing that we do is, for example, go with the mini microscope and try to catch the ureteric catheter and put the substitute guide wire, the pyramid say, and put it through and through, and fix it through the urethra and through the kidney. That will stabilize the kidney during the dilatation.
Actually, I looked at it in the literature. I mean, I find some cases reported about the best solution for it. Some of them said, as the Umar said, that would be putting a Foley catheter and inflate the balloon. You can pull the kidney toward your side, or you can ask one of your colleagues to push from the other side both kidneys to your direction while you are operating. So this is was the most answer to my question, but I highly appreciate your explanation. It was very good explanation and good answers.
Is a 39-year-old male patient, previously healthy, presented with 1 year history of right renal colic. The pain score was 5 out of 10, and it was associated with bloods. There was no fever or vomiting. This is the CT we did, and as you can see, he has a left distal ureteric 1 centimeter stone, and the left ureteric 1.5 centimeter stone, and the right staghorn stone in a horseshoe kidney. This is the other image. He underwent a bilateral DJ stent fixation, and after a moment we did a DEMSA scan, and it confirmed that the right kidney is 82% and the left is 18%. So your suggestions?
We will go through the sequence again.
First of all, this patient has bilateral kidney stones. His renal colic was right-sided.
Yes.
Despite the 18%, most of adult urologists with upper nephrectomy for that percentage, less than 20%. With stone formers, I tend to go with a pediatric urologist, go to 15%. So I will try to preserve the left kidney, though he was asymptomatic. So I will try to treat the left kidney stone. You already put a stent on the right side, though to me, I don't see any evidence of obstruction to have renal colic. I couldn't see the CT very well, but there is no urethral stone on the right side. So I'm concerned, why would the patient with that staghorn get a right renal colic? In any event, I will see if he doesn't have underlying medical condition. As we all know and teach, when you have bilateral stone disease, you rule out hyperparathyroidism or other medical disease before you continue surgical management. So my answer is left ureteroscopy, clear him, then address the right side.
You mean the left side is a flexible ureteroscopy? You start with the rigid, then you flexible ureteroscopy, right?
Sorry, what's the stone burden on the left side again?
The kidney stone was 1/2, and the distal one is 1 cm.
I would go with mini perk and do an antegrade ureteroscopy on the left side, and do both stones on a prone position. We tend to do those with ureteric stones. You can do first ureteroscopy and break it, or then do the kidney stone, but that's one option. But I think that this, with the horseshoe kidney, as you showed, it's difficult probably to access it with the ureteroscopy and do both on one side. The other issue with those patients, they may have limited access to health care. So if this guy is covered, or his coverage is limited, I'll try to do everything in one admission, because in my country, some of those patients may have only one chance to have those procedures. So what Dr. Sam has showed us to do with those bilateral options is there. Though the right side has significant stone burden, I would like to do it in a separate setting.
Okay, I agree with all of your comments there. I think even though there's poor function in the left moiety, it looks like the parenchyma has certainly been significantly thinned. I think you'd want to try and at least de-obstruct that side, I think, because obviously with obstruction, it's hard to assess renal function accurately anyway. Plus, it could be, risk of sepsis and so forth from obstruction. And doing a partial nephrectomy in the horseshoe kidney is never easy undertaking, so we want to avoid that if we could. So my approach here would be to tackle the left side first, to clear out that ureteral stone burden. And I probably would have a look up with my flexible ureteroscope. That infundibular pelvic angle doesn't look terribly sharp to me. I'm not exactly sure I know where the UPJ is, so give me a good chance to assess that. And I might attempt flexible ureteroscopy and deal with that stone, but the ureteric stone burden definitely needs to be dealt with first. The right side, you have them stented, that one's protected. If ultimately he needs a PC down there, then I would deal with the left side. Single procedure first, assess the renal stone after you take care of the ureteric stone, and then stage and tackle the right side percutaneously.
So you don't agree with the idea of mini back on the left side, especially with the thin parenchyma and I wonder, like, would we start with a less functioning kidney before starting treating the normal functioning kidney?
Yeah, well, again, you've got an obstructed system there, so I think you want to deal with the obstruction. Porking a kidney that has very low parenchyma is not a very easy procedure to do. I mean, the bleeding is greater. Even if it's mini PCNL, you don't have parenchyma tamponade, so I'm always cautious about perking a kidney that has very low parenchyma. I think you want to do as least as possible to this left side. I think it's already significantly damaged, and you could almost make an argument that even if you deal with obstructing ureteric stone, it's not going to get any better. So why even bother putting them through something as invasive as that? So my thinking is you want to do as least as possible on that side, so that you can get yourself set up to tackle the right side, which is the more important one. It's the one that's got the better renal function and the one that you want to preserve.
I think, as said by our colleagues, it is better to finish the left side, either ureteroscopy and the flexible, or even push back and both of the stones PCNL standard to decrease the time of operative time. And for the right side, it will need a separate session of PCNL standard. It's better to also to save time. To do both of them in the same session, I think it will be very difficult and need more prolonged time of PCNL and the hazard of the prolonged anesthesia and even the wash all the time of all the complication of prolonged treatment.
I agree with all the comments. The question here, whether to do simultaneous bilateral endoscopic surgery or not. I think it depends on the instrument that you have available and the hardness of the stone. You put a digit stent already on the left side, so I would start with puncturing the right side and checking the stone. Especially now we have, disintegration devices that have powerful disintegration devices like the EMS Trilogy or Olympus Check Pulse, which has the suction and the lithoplast. If I'm going smoothly through the right track, I would then do an IVP, a retrograde parallelogram in the same setting, just to check the system on the left side and decide whether to go for flexible ureteroscopy if the anatomy is favorable, or do a PCNL, and not necessarily at the same time. It depends on how the system goes on the right side.
Most of you don't agree on left nephrectomy. So most of you wanted to save this left kidney, although it's thin parenchyma and with a functionality of 80%. So most of you agree that we should treat this kidney and not to leave it alone, right?
If it is possible to revise the radioisotope scan after the resistant, you can.
Actually, the DEMSA scan was after by 1 month.
Yeah.
After 1 month from fixing bilateral the resistant, that was the patient.
Maybe if this kidney is not a horseshoe kidney, maybe the decision will be different. If it is normal kidney, not horseshoe kidney, I'll take the decision of nephrectomy. But still, the heminephrectomy in a horseshoe kidney, it is not an easy one.
Sorry for interruption, but I did a couple of cases of heminephrectomy in horseshoe kidneys. One of them a few months ago. I will approach this case different. I'm not a PERC guy, I don't do PCNLs. I think if you do PCNL and this poorly functioning kidney, you will damage more nephrons, so you will lose more cells. So this kidney will be more poorly functioning. What I will do, I will take out the left moiety, and in the same session I will do laparoscopic pyrothectomy on the right side, because the stone is mainly in the renal pelvis, in the right kidney, and in horseshoe kidney, the renal pelvis is pointed anteriorly. It's very easy to open it and take the stone in one session. And even if you, but I don't think you need to correct drainage, because the kidney is not hydronephrotic and there is no significant obstruction. So what I will do, I will take the left moiety and take the stone at the same session from the right moiety. Laparoscopy.
What about the fact that this patient is forming stones and a stone former, and if you take this 18%, which is 18% with obstruction, so this might actually improve the 18% after obstruction. So 18% plus minus, okay, that might help the patient in the future. What do you think about that? Yeah. Maybe flexible ureteroscopy and deal with the stones at the left, Dr. Ahmad?
I think Dr. Desai from India looked at renal function and PCNL post in renal impaired patient, and they do improve. The other thing, a lot of urology colleagues who don't deal a lot with stones don't know about the recurrence of stone, pediatric stone. Those with, it's not unusual for someone like this, I don't know what's the Hounsfield unit, that he will come 1 year later with another stacked bone. So I know, Dr. Ahmad, you're a skilled laparoscopy, you do donor nephrectomy and the most difficult ones, but I know you're tempted, the pelvis is there, and you just open it and take it out. But you'll be surprised how much those stones will be stuck sometimes, and you will be surprised with the no ability to do intraoperative fluoroscopy that you are left with stone, then you will perk or do ureteroscopy. So the point I want to send to skilled laparoscopists, though the literature has increased robotic and laparoscopy, stone removal still, percutaneous surgery is less invasive than laparoscopy. And the other thing is that in someone with bilateral stones who hasn't been investigated for metabolic disease, don't lose any nephrons. And we know from the literature that PCNL does not increase loss of renal function. That has been demonstrated in animal model and in human model. And the latest literature published from London, Ontario, Hassan looked at a database of more than 2,000 cases where they compared pediatric to adult and found almost no increased renal loss, despite that in London they used the same the adult instrument, and we know the literature, they didn't show much differences. Keep the nephron.
All right, any comments or any questions? All right, thank you very much for the panel. Thank you for the presentation. I think this concludes our session for today.